Unfortunately enough, we can see that although cardiovascular mortality and morbidity is still very high in Israel, it's decreasing slowly, and it is mainly because of what we are doing to prevent the cardiovascular disease. It's very important to do all the invasive cardiology, and I'm not going to dare and stand here and say that this is not very important, but according to the literature, the majority of this reduction, or the major part of the reduction, is actually coming from prevention of cardiovascular events by treating the atherosclerotic lesion, which is basically a systemic disease. It's not just one lesion in one coronary artery, and therefore in many different countries it's very clear that the work that we are all doing both in primary and secondary prevention is very important in decreasing the mortality from cardiovascular diseases. Unfortunately, cancer is staying the same. Although we put a lot of effort in treatment of cancer, it's still staying the same, and it's quite high. It's about a quarter of the patients dying from cancer. When we are talking about how can we improve our ability to prevent the cardiovascular events, of course there is no question about the patient who is a very high risk to develop cardiovascular events, because we are going to treat very aggressively all these patients. And there is no question about patients that has no risk factors, no risk for atherosclerosis and cardiovascular events, because we don't want to treat everybody. We don't want to add statin to the waters. Every compound that works has some side effects, and there is no question that we don't want to treat everybody. The majority of patients in primary prevention coming from what I marked in yellow, which is a moderate risk. And that's the classical patients that Professor Lewis described as the patients that coming as first event many times with acute MI or sudden death. And therefore we are in a fishing expedition. We're trying to fish the right patient to treat when we lose them, when we just use the Framingham criteria. And as we all know, we cannot really foresee the future, and therefore it's very difficult, and we need to guess, and we need to use a lot of different tests to find out who is the one that we really want to treat. And it's not just a decision to treat. You start treating the patient and they come in with some muscle ache. If you really know that this patient is at a high risk, you can always talk to the patient and find a way to keep on the treatment. If you yourself not sure that you really need to treat this patient, why would you change his life with something that you're not sure that's going to change anything? So it's very important to know who do we want to treat, who do we want to persist on treatment. And this slide is very important, so you see it for the second time. We don't want to miss this very big amount of patients, the number of patients that we do see again and again, that unfortunately coming to the emergency room and getting into the intensive care if they are lucky, and all of a sudden, of course they shouldn't get statins, of course they should get the treatment for their blood pressure and a little bit of glucose and for the lipids, because now they are at a very high risk. A week ago, they didn't qualify to get any treatment. So that doesn't make sense biologically. And we know that we are in this position, and many patients below 100 milligram per deciliter will have a heart attack, and we know that a lot don't have any risk factors, and about 3/3 of the patients actually don't qualify for treatment before they had their event. And that's especially true in Israel and in the United States. Maybe it's not true in Scandinavia, and some of the studies has been done in countries where the risk factors are much more prominent, but in Israel it's very clear. The problem is that we have so many tests that people suggest that we should do, and how do we pick the right one that we want to put the effort and really do it for our patient in the clinic, and not just have it as a very nice, sophisticated, scientific, experimental test. And I put on some imaging tests that are possible, but it's on a very shaded way because we are not discussing it. And I put on very many biochemical biomarkers. And of course, we are going to talk today about the plaque test and LPPLA2, and why did we start screening a lot of patients in Israel now with this test. Usually we try to put on the clinic only tests that we quite sure that the evidence is strong. question is how in this big forest of chemical biomarkers you pick up the right ones. So there are a few criteria that one should go when you pick up the right test. First, it should make scientific sense. Usually when you have a lot of scientific evidence, it doesn't mean that it will work in the clinic, but when you have no scientific sense, you can be for sure that that's not going to be something that works. The second thing is that we want to see this biomarker in the scene of the crime. It has to be in either the lesion itself or in the immune system affecting the lesion, but it has to be somewhere where it should have an effect on the process or on the disease. Of course, the marker should be very important at different stages of the disease. If the marker is something that you do see only after acute MI, it's not going to be a marker that will teach me which patient I want to treat. If the marker is only high when the patient are 3 years old, it will tell me if at the age of 60 they will have an event, it's not going to be very helpful. So we would like to see a marker that you do see in a high level at very different stages. And of course, the best thing is when you change the marker, you change events. But that's only come quite late because these studies cost a lot of money, and at the end of the day, if there is no drug that treats specifically this biomarker, we'll never have a study like it. So let's go over these 4 or 5 very important points. So the first thing is we know that, as Professor Lewis was saying, that 2/3 of patients actually having their events because of a rupture of a plaque, not just because of stenosis, and that tells you that you have an active biologic process, usually with a lot of involvement of inflammation. And you've seen all this, that LPPLA2 play a major role in the pathophysiology of the plaque formation, and I'm not going to go through all of it for the sake of time, but it's very important for endothelial dysfunction and for the way that oxidative LDL is actually gets its effect on atherosclerosis. And actually LPPLA2, the enzyme, is a protective enzyme that prevents the development of atherosclerosis, because when you get the product of this enzyme, actually you get 2 products that are very atherogenic. So the more enzyme you have, the more atherosclerotic or the more ruptured plaque you will have. So we would like always to have a low level of this enzyme, both in activity and in mass. And when you take one of these end product of this enzyme, the lysophosphatidylcholine, you do see that it has many biological effects that will increase the development of atherosclerosis. So therefore, the activity of LPPLA2 can be not just a marker of activity of a plaque, but also a causative role in the development of atherosclerosis and rupture. And even in a paper that was claiming that maybe not all the epidemiological studies showed the efficacy of testing LPPLA2, even in this paper, in the introduction, it was very clear that scientifically LPPLA2 play a major role in the pathophysiology of atherosclerosis. The question, of course, would it have similar effect when we test it in the paper? The second thing, of course, as I was mentioning, is do we find it in the lesion itself, and does it correlate with the amount of lesions that we do have? And the answer to the 2 questions is yes, as you will see. First, when we do stain for LPPLA2, we do see that there is a LPPLA2 mass. Later on I'll show you activity in the lesion itself, and it correlates very well in the places where we do see the rupture. When we do have a thin fibrous cap, and when we do have the monocytes in the shoulder of the plaque, where usually we get the ruptures, which I don't need to teach any cardiologist, but that's usually where we do get the rupture. So it's not just in the plaque, it's in the right places in the plaque where we do get the ruptures. And as you can see in a quantitative way, the more prone the plaque to be ruptured, or even if it's a ruptured plaque, the more LPPLA2 you see. But to be scientifically honest with you, you do see that the standard deviation is quite high. So there is a variability between patients. doesn't mean that if someone has a low LPPA2, you can tell them, okay, go home, stop the statins, I don't care about your other risk factors. Definitely, if it's high, it tells you. If it's low, it doesn't mean that the patient is better. And we have to be very careful. So only it has a positive predictivity. The other thing that we can do see that this biomarker is actually produced within the coronary artery when we have atherosclerosis. And you do see here on the left side in the red bar that when you have a lot of atherosclerosis in the coronary artery and you collect blood from the coronary sinus, you do see a lot of LPPL2 muscle activity. You don't see it when you don't have the atherosclerosis, and you don't see it with CRP. So in CRP, it's a general biomarker. It's a systemic biomarker, while LPPL2 is a specific biomarker of atherosclerosis. Only where you have atherosclerosis, you will find the enzyme, and only there you will find it in the blood. More than this, when you use IBUS and you collect blood, you can see that there is a good correlation between the amount of atherosclerosis and the level of LPPL2 that you do find in the coronary arteries. And you do see basically that you don't get an increase when you have systemic inflammation, unlike CRP. So the patient can have a flu-like syndrome or a flu or a hepatitis or whatever. The LPPL2 won't increase. So it's a specific marker for the atherosclerotic lesion, unlike CRP, and the variability between a day-to-day is very small. So now I could conclude my talk and say, look, this is a specific biomarker for atherosclerosis. It's actually tell us if you have an inflammation in the artery. Let's test everybody. The problem is, and I will mention it here because it's clear, that to test for CRP is few shekels. To test for LPPL2 is about 400 to 500 shekels. So it has to be really a good biomarker to do it. It's not a lot of money when you compare it to other studies that we do to our atherosclerotic patients, but it's not something that you just do because it's nice to do. Because it's cost a little bit of money, and it costs money because you need an ELISA to do this test. It's a very specific test for activity of the enzyme, so it's not something that you want to do to everybody. You want to do it in a small group. Of course, we want to see if it increased in the different stages of the disease, as I was saying. So I'll go quite quickly on part of this clock of the development of the disease, the timeline of the development of the disease. So even before we start having the atherosclerotic obvious, and we just have the risk factors, we already start that LPPL2 can be a very good marker in many different primary prevention trials to predict that this patient has a higher risk for cardiovascular disease. So it's not just one study, in many different studies it's very clear that even in primary prevention you can predict it, and it's not something that if you have 232 it's different than 276. You really need to categorize this patient according to quartiles, and basically if you are in the top 2 quartiles, the risk is increased, and that's a patient that has a higher risk of cardiovascular events. And I'm just going to show you a few of the papers that looked at it, and in this paper they looked at many different patients, so it's a clinical immunological studies. This is almost 13,000 patients. There are studies that actually show the relationship between LPPL2 and CRP and the risk of cardiovascular events, and one can see that both of them actually works, and when both of them are increased, it's increased the risk in a dramatic way. And it doesn't matter if a patient has other risk factors. If you look just at model 3, when they normalize for everything, for sex, for race, for smoking, for LDL, HDL, diabetes, and high sensitive CRP, still the increasing risk is very high. So this biomarker actually can tell us this patient is really in a high that's very important because LDL is not a very good predictor for the patient that will develop a stroke. Definitely is when we talk about primary prevention of stroke. And this is, as far as I know, almost the only biomarker. I never say in medicine the only biomarker, but as far as we know, it's the only biomarker that actually can tell you that this patient is at a higher risk of stroke. And that's very important because stroke is a major problem to our community. And it is true in every blood pressure. So it doesn't matter that the patient is hypertensive and then I say, well, then I don't need this biomarker. In every blood pressure, this biomarker can be a very good predictor for stroke. And if this will be the only thing that you will take home from my lecture, that's it. Because this is a major thing, and that's why that we do insist having this as if we look about patients that already start having endothelial dysfunction, this is working as well. And this is a very good predictor of endothelial dysfunction. So if one has a high LPPLA2, I think that you don't need to look for endothelial dysfunction. You can always guess already that this is where we are. And you can see that this is an excellent predictor because they are coming together. It's what we're talking about, the inflammatory process. It's even more significant than all the other important diseases. We all know that I'm a lipid. So I should always preach for the lipid. But in this case, this is a very important inflammatory thing for the lipid. And that's true. It doesn't matter how you measure this endothelial dysfunction. When we talk about the diabetic patient or the patient with metabolic syndrome, again, we do see exactly the same thing. And I took this from the West of Scotland study because I don't believe that the West of Scotland is really a primary prevention trial. I think it's a metabolic syndrome trial. When you look at the patient, basically they have a metabolic syndrome, most of them. But you do see something which is very nice here. When you look at the fifth quintiles with CRP and you correct it for all the other risk factors, it already has no effect. But with LPPLA2, it doesn't go down, even when you correct with other risk factors. So this risk factor, because it's produced within the atmospheric region, it stands for itself, and you don't need you cannot just say, well, I measure blood pressure, I measure LDL cholesterol, why should I spend the money on this? And the same thing is with diabetic mellitus. You do see that it correlates very well, and again, you see that we are not talking about numbers about tertiary or quartiles of this test. And the same thing you do see with the metabolic syndrome when you have a high LPPLA2 and the metabolic syndrome. The chances to develop cardiovascular event is so much higher than a patient that has no metabolic syndrome and no high LPPLA2. And if you have just one of them, it's in between. So this is becoming very important. It actually tells us a lot about the chance of cardiovascular events in stable angina and in myocardial infarction. And this just to summarize different secondary prevention trials that the patient was tested in, and you do see that in basically almost all of them it was statistically significant, all of them. And again, if you have a low, it's very nice. When you start having a high LPPLA2, you are at risk. And therefore, when we give the results, we do say that below a number, you are at low risk. In between is a gray zone, and above a number, you are at high risk. And from there, I don't know if it's a 2 out of 70 or 4. And the same thing is coming from another study of about 500 patients. I will show you many different trials at least that has been showing that basically when you start having a high LPPLA2, you don't need to get to the very high level. You already start seeing an increase in the cardiovascular risk, even in secondary prevention, especially in patients with stable angina. We all know patients that had acute MI 10 years ago, now with stable angina. We usually don't treat them very aggressively, unfortunately, and maybe that can help us, or sometimes can help the patient. Because the patient already feels secure, and I don't need much of this treatment. If he does see that this biomarker is very high, sometimes it's helpful to doctor convince the patient to take this drug, and as you can see, basically it all depends on the level of LPP you get to this. And the same thing is with myocardial infarction, and one can see that the higher that you get, and we didn't measure it just after the myocardial infarction because then you have a whole inflammatory process, so we took it 3 months later, and if 3 months after myocardial infarction the patient have a high LPP-2, that means that the atherosclerotic biologic process is still going on. And if it's still going on, it is not beyond the acute phase for the atherosclerotic lesion, and we need to treat these patients very aggressively, and it's as important as measuring LPP, which usually tells you about the heterogeneity of the lipoprotein that the patient has. So that's very important, and when one look at aggressive versus less aggressive treatment, the PROVI trial that we all know and the compared bravastatin to atorvastatin, one can see that basically it's not just the aggressive treatment, not just to decrease LDL, it's also decrease the activity and the mass of LPP. So when you look at the end results and you say that there are less events, part of it was probably absorbed. It's not just because you change the lipid, but you could change the biology of the stroke is very important because, as I was saying, cholesterol is not a good predictor, and as you can see, both activity and mass are very good predictors, as good as systolic medication. Smoking was only one better predictor than and unfortunately we don't see this in stroke, we just do see it in ischemic disease, and later on in our discussion Professor Ornstein can elaborate more on this. So cholesterol, although I'm a little bit, is a very disappointing predictive factor for stroke. When you look at stroke and you try to see if other inflammatory biomarkers are very important, because maybe just inflammation is important, one can see that CRP is not, and LPP-2 is. So LPP-2, because it's a specific biomarker of biological inflammatory activity within the plaque, is basically the only predictor for stroke. And therefore, this is very important when we do think about it, and definitely in families where there is a history of stroke, we do look at those things. Do the plaque test more than once in their life and see if it's increasing, then we want to try and see how we can prevent it. And basically we can see that it is within the plaque, as I was showing you, in the carotid arteries, and much more when you have plaque which is non-stable plaque within the carotid artery, and this is one of the things that has been shown. But not just that. When you do see LPP in carotid arteries, it's a very clear biomarker of this patient with high risk to develop cardiovascular disease as well, because this is a systemic disease. And if you find inflammation in one artery, you can assume that you have it in other arteries. So this is a very important. I'm not going to the other things for the sake of time, but let's go to see first, can we reduce it? Because if you have a biomarker and you cannot change the activity or the biological activity of the plaque, so what's the why to do this? So of course, we need to see if the drugs that we are using nowadays, the medications that we are using nowadays, can reduce LPP-2, and of course, are we going to have in the future maybe compounds that will work directly on LPP-2? So one can see that almost all the compounds that we are using to reduce LDL works as well to reduce LPP. So that's why, if the patient is at a very high risk, I'm going to treat anywhere aggressive. I don't have to specify. If I have a question, how aggressive treat the patient, or what to treat the patient, LPP-2 test will be very helpful, and I know that if that's the case, if I treat the cholesterol aggressively, I will treat the LPP-2 as well. Basically, one can do it and can see even show that there is a good correlation between the reduction in FP-PLA2 and a reduction in the plaque. Of course, it doesn't tell us that FP-PLA2 is causing the disease because the drugs that we're using reducing LDL as well. So only when we have a treatment that is specific to FP-PLA2 we'll be able to do a study like that, and there is one, and we'll get to it in a moment. That's showing basically very similar things, and in the lipid trial they could show that there was a very good correlation between LP-PLA2 reduction and the event. Well, that's a post hoc analysis because the study was actually planned for lipids, and we always know that that doesn't teach us that much. Therefore, we are all looking for the rapidly a trial that is now occurring, unfortunately, not least in other places around the world. And this is a drug that actually works very specific to block this enzyme and reduce its activity. And as you can see in animal models, it reduced the way. Using this imaging technique, I'm not sure how much you can really trust this imaging technique to predict cardiovascular events, but eventually it looks that it should change the plaque composition and reduce the lipid probe in the plaque. But right now there is a big trial done in about 15,000 patients around the globe with an endpoints to see if treating directly LP-PLA2 will reduce effects. I'm not sure that this study will be a positive trial. First, because it jumped from a relatively small imaging trial to this big trial. But if it will become positive, then definitely we would like to test for the LP-PLA2 and treatment patient according to this. But even if it's come negative, it doesn't mean that this is not a very good diagnostic information. It does mean that it's specific. That's not going to change the disease. So where are we right now? There's no question about patient with low cardiovascular risk. I'm not going to recommend lipid-lowering drugs to the world. And we have no question about patient with high risk. That's a lot of patients. But I'm sure that a lot of us do see this patient as moderate risk, and we ask ourselves, do we want to treat them or not, even if we don't qualify a fairly area, or do we want to treat them just for LDL goal of 30 or 100, or we want to go lower. And of course, if we have a high LDL, there is no question that we want to get LDL. And the same thing is with the patient who is in moderate higher risk, and we want to give them or get usually to 100 LDL as a goal. We would like to get them even lower if we do see a high LDL. And it's not just my idea, it's all the organizations that take the same way, that the evidence that we have right now and the data that put us to the point that we do need to treat the patient this way. This is just to summarize the different levels of evidence that we have for the plaque testing before we conclude many studies, including, and that's why all the agencies actually recommend to do this test. And even reports lately in Lancet has recommended to do this test in patient with medium risk or patient with secondary prevention that would like to know if it wants to treat them more aggressively. And I will conclude with this